Thanks for having me today. I'm glad to join you. Today, I'll be discussing the role of helogravity traction in management of spinal deformities. Pediatric deformity has been commonly classified as congenital neuromuscular and idiopathic type, with the adolescent type being the most common, as well as sagittal plane deformities. Neuroclassifications identify all curves before the age of 10 years as early onset scoliosis, and they're subcategorized according to the etiology as congenital, neuromuscular, syndromic, or idiopathic. And I'm not going to go into details. I believe it was covered in another talk. But it's important to understand that the natural history of early onset scoliosis is very different than the adolescent idiopathic type. Some early natural history papers found that cardiopulmonary complications can cause as high as 18% mortality rates in this patient population, with a high progressive curve as almost 5 degrees per year. And this is just x-rays for patient. You can see how high the curve can get if left untreated, if it starts early onset, like at age 2 or around that age. And again, this is very different than the adolescent type, where the natural history is pretty similar to normal population. So the challenges with early onset scoliosis are usually that you cannot really fuse them early on, because that will cause thoracic insufficiency and decreased pulmonary functions. And you also know that the most rapid phase for thoracic growth is in the first 5 years of age, and then it tends to decrease in velocity afterwards until the growth spurt. So management of early onset scoliosis for the mild or moderate curves has routinely been growing rod constructs, but it's important to know that there's a higher rate of complication for every episode of surgical lengthening, as high as 24% addition in complication rates. And there's a 13% decrease in the complications the later you start the initial implantation. So some authors have recommended the age of 7 as the time to start growing rod constructs, provided that the curve is not getting too big. Newer technology, such as the magic rod, have helped a little bit in this front with decreasing the complication rate, since the growing can take place in the office. So that leaves us with the severe rigid early onset curves, and we have to make a balance between the curve progression control and allowing the thoracic spine to grow at the same time, along with the pulmonary function. So it's also important to note that acute correction of a large rigid curve is very difficult, and it also increases the risk of neurologic complications. And at the same time, those patients usually have pretty low pulmonary function and usually malnourished as well, so that makes it more difficult to have the surgery right away. The concept of traction actually is not new. It's been around for many years. This is Hippocrates, and he was one of the first people to describe scoliosis. He even had a traction device and ladder called the Hippocratic ladder, where they did traction on those patients, pulling on from the neck or the legs to help with deformity, and even a board where they can use their whole body weight to correct it. So the same concept applies now. So the goal is to do gradual correction of a rigid curve, and that would allow stretching of the soft tissue around. One key point also, it helps with neural element elasticity, and makes it less prone to injury during the corrective surgery. Other indications would be if you have a patient with acute neurologic problems and you want to optimize them or wait a little. And there's been some reversal on some patients. If they have neurologic complications, you could reverse with some traction. Now, many studies have looked into this, and one of the earlier studies in 2005, they looked at 33 patients with rigid scoliosis with curves of average of 84 degrees in the coronal cob and 78. The curves were not that high, but they found that they could get of correction uh, after final surgery when combined with the traction, and they found no permanent neurologic complications. Later, there's been more studies looking into this, and this study compared 30 patients who did halogravity traction with 23 patients who did not. And what's important here is that they found that the need for vertebral column resection was higher in the non-traction group, and also the associated complication rates were higher. So they concluded that traction can help reduce the need for complex osteotomies in those patients and reduce complication rates. Obviously, the hospital stay was longer in the traction group. Another study looking at 33 patients with pre-op halogravity traction, they found an average correction about 35 degrees in both coronal and sagittal planes, and they found 20% improvement in the pulmonary function. That was significant. Most of the correction was obtained the first 3 to 4 weeks, so that's a very good benchmark there. And most complications were related to pin site loosening and infection. There were no long-term neurologic complications in this cohort. So another good article that pertains to early onset scoliosis is this study by Bawacci et al. They looked at 30 patients who did halogravity traction with no anterior release, so no prior surgery, and they got up to 29% correction after implantation of the groin rods. The only complications they had were pin site infections. They did have a progressive infection that went into a cerebral abscess, but generally there were no neurologic complications. So the conclusion was that preoperative traction in severe early scoliosis can help make a curve amenable to rolling rod constructs. So the contraindications for halogravity traction can pretty much be if you have a cranial injury where you can put the halo, or if you have cervical kyphosis or severe stenosis, some ligamentous laxities, or neurologic deficits after you've used the traction. Obviously, you have to stop it at that point. There's been variability in the studies about the ideal amount of time to use the traction, but most have concluded that you get pretty significant correction after 4 weeks of traction. So one study showed 66% improvement in correction in only 2 weeks, with up to 90% after 3 weeks. So most complications are related to pin site infection, but there's been reports of cranial nerve injuries as well. So when placing the halo pins, it's important to understand where exactly to put it. It has to be below, the halo has to be below the equator, and you are aiming for the lateral two-thirds of the orbit to avoid the supratrochlear and supraorbital nerves. You use 6 to 8 inch of torque on those patients. And the traction protocol is pretty simple. The goal is to reach 20 hours or more per day, and that means they have to be in traction in bed, standing, walking, and wheelchair. And you initially start with 20% of the body weight, and then by the end of the first week, you move to 30%. Second week, end of second week, you get 40%. And by the end of third week, you should reach 50%, provided there were no other complications. And this is just how the patient looks in traction, and the same applies when they're in bed or in the chair. The wearing schedule, as we said, 20 hours should only be discontinued for bathing or toilet activities. You can, or eating, but they can also eat while in traction. Pin site maintenance should be daily hygiene for cleaning. Once a week, you can tighten the pins, and you should do daily neurologic examination, including cranial nerves. X-rays, usually you have to allow enough time for the traction to work. So every 4 weeks or so, you can get a full spine X-ray. With the cervical X-rays, preferable to get weekly to avoid any more distraction. Daily exercise can really improve their pulmonary function and help avoid disuse atrophy. So we'll go through a quick case presentation. This is an 11-year-old patient who had neurofibromatosis, multiple growing rod procedures that ended up with infection, and they had to remove the hardware. And unfortunately, after that, her spine completely collapsed. She was still neuro intact though. So if you look at her images, there's a very severe deformity in both planes. Those are her images. Um, she had a kyphosis about 121 degrees, but that's just on X-rays with compensatory lordosis. And even on the traction films, the curve did not improve much. And again, it's very difficult to see the actual focal kyphosis. In those patients, if you get a CT scan, you'll see that her focal kyphosis even up to 160 degrees with multiple level collapsed and fused together. Fortunately, she had no neurologic element problems aside from dural aphasia, which is something common with neurofibromatosis. So stage one was applying the halogravity traction. The goal was to reach 50% in 20 hours, or 50% body weight in 20 hours a day of traction. After 1 week, you could start to see some correction of her curves. Kyphosis going down to 97 degrees. Um, After 7 weeks, the correction is even better. So after 7 weeks, it's about 45% correction in the thoracic curve and about 25 correction in the kyphosis. So that was a good time to do your final surgery, which was a T2L3 VCR at T8 to 10. Patient position, you can use Halo intra-op as well, but you only do 50% of your pre-op traction to avoid too much tension in the neural elements during surgery. And this is just a surgery. You have to get your fixation points, use a temporary rod, then do decompression of the VCR and start correcting the curve, correcting the deformity. And she had a very big dural exposed dura, so we used a mesh cage to cover that up, and also had multiple rods for stability. This is a pre-op, and this is the immediate post-op or intra-op. She was neuro intact on exam. Post-op, she stayed in a brace for a couple months and had no neurological long-term complications. So this 1 week post-operative, you can see the kyphosis corrected down, and as well as the scoliosis. And this 6 weeks post-op, and those are her images. And she got pretty good correction. So the take-home message that traction is a valuable and effective option for initial management of complex rigid curves, usually above 100 degrees. And it can decrease the curve magnitude preoperatively, thus decreasing the risk of neurologic complications intra-op. And also has a very good role in improving pulmonary function, which decreases the anesthesia risk and also help the patient with nutrition pre-op. So in many cases, it can avoid the need for complex spinal osteotomies if enough time is allowed for traction. And thank you so much.